Swayam Prabha. Digital India. Educated India.
I am Dr. Sandeep Mathur, and today I am going to be talking about benign diseases of the breast. Now, before I bring my lecture, I would like to say that some of the content in the lecture has resource material from the internet and is being used purely for educational purpose and not for any commercial gain. The outline of my talk is going to be on the normal anatomy of the breast, physiological changes, developmental abnormalities, inflammations, non-proliferative breast disease, proliferative breast diseases, adenomas, and the benign stromal tumors. Now, most of what I talk today is going to be pertaining to the female breast. However, one must remember that the male breast is also amenable to same pathological changes which I am going to briefly talk about, although their incidence is considerably lower. The breast, if you look at the normal anatomy, it is nothing but a modified sweat gland that lies between the superficial and the deep layers of the chest wall. Before puberty, the breast in both sexes comprises mainly of ducts. Now, as the female breast matures with growing age and especially after puberty, and majority of the changes which occur in the female anatomy occur during pregnancy and lactation. So if you look at a mature breast, it comprises of around 15 to 20 lactiferous duct which originate in the nipple. They branch into ductules and culminate ultimately into what are known as terminal duct lobular units. So in this diagram over here, you can see that each of these 15 to 20 ducts which I talked about comprise of collecting ducts. Then there is a dilated portion in the duct just below the nipple, which is known as the lactiferous sinus, where milk is stored. Then there is the segmental duct, the subsegmental duct, and the smaller branching ducts which culminate within into grape-like structures which are held together by a specialized stroma which is myxoid in appearance. These are known as the terminal duct lobular units. These are the secretory units of the female breast, and each of these secretory units is known as a lobule. So you can have a duct which is outside this specialized stroma and a ductular portion which is inside this specialized stroma. If you take a cross section of these ducts, they are basically lined by a dual layered epithelium, which is a luminal epithelial layer and a basal myoepithelial cell layer. The rest of the breast comprises, that is, lies between these ductular structures, is mainly fat and fibrous tissue, predominantly fat, which is held together by the Cooper's ligaments to the chest wall. So the entire breast is, depending upon which phase of the female reproductive age it is, it varies in its anatomy, and the peak changes are seen during pregnancy and lactations. The breast is naturally very hormonally responsive to estrogen, progesterone hormones, which are the main female hormones. Now, this is the actual histology of these terminal duct lobular units which I just showed you. So you can see that these are the smaller ductules and the acini. So you can see this is the central ductule which is lined by these small glands which are the acinar or the secretory units. This is the higher magnification showing the ductule surrounded by these acinar structures. And as I told you, it's a dual layered epithelium. You have a luminal epithelial cell layer and the basal myoepithelial. These arrows are pointing to the myoepithelial cell layer. Sometimes these myoepithelial cells, they appear very clear in appearance. And this is the fibrous stroma around the breast. If you look at the development of the breast ductal tree, this occurs mainly after birth. So there are very few ductules. They go on as the age advances, they go on elongating and branching under the influence of estrogen hormones. And after puberty also, there is a considerable branching and elongation of these ductular units. And it is only during pregnancy under the influence of progesterone hormones that you start getting these dramatic changes or branching and differentiation of these ductules into secretory units, which are known as the acinar units. So as I told you, estrogen results in development of the breast and the lactiferous ducts. Progesterone is mainly responsible for the secretory acinar tissue, that is the lobules, and prolactin is a hormone which synergizes the effect of estrogen and progesterone. Now this is the higher magnification of the cut section of a duct. You can see this is the actual way it appears. This is lined by a columnar epithelium which may be slightly stratified, and these apical snouts are the secretory units which we call as the apocrine snouts, and there is a basal layer of epithelium, second layer of epithelium which is known as the myoepithelial cell layer, which is different from the epithelial cell layer. So a benign breast lesion will always have a dual layered epithelium. Now as pathologists we are heavily dependent upon these myoepithelial cells for characterizing a lesion. As I told you, all benign lesions have an intact, by and large, an intact myoepithelial cell layer. Now these myoepithelial cells you can see sometimes in histology, but in a proliferative lesion you may sometimes have to resort to immunohistochemical stains or markers to highlight. Now these are enlisted over here. Here are some of the myoepithelial markers like alpha smooth muscle actin, cytokeratin 5 by 6, which is a high molecular weight cytokeratin, CK14, P63, caldespone, and calponin. So you can see this is a smooth muscle actin, which is highlighting the myoepithelial cell layer, and this is a P63 stain, which is a nuclear stain, which is again highlighting the myoepithelial cell layer in a breast lesion. Now coming to some of the physiological changes which occur at birth, you have the male and the female breast which actively secrete unit. Now this secretion is mainly because of the transplacental passage of maternal hormones. So you may have bilateral breast enlargement and colostrum like secretion which is known as the witch's milk. Now this automatically recedes several months postpartum. And after menopause, also some changes occur which are physiological. These are gradual and progressive involution, which means that these lobular unit, terminal duct lobular units, they undergo atrophy. The fibrous tissue is more or less replaced by fat, and there is maybe some cystic dilatation of the duct. Another condition which may be an exaggerated form of physiological change is macromastia. As you can see in this patient, there is diffuse enlargement of both breasts. This occurs predominantly during adolescence or pregnancy. It is due to an exaggerated response to hormonal stimulation. Another condition, it is sometimes also known as pubertal or virginal macromastia. It may also occur during pregnancy. It occurs in 1 lakh pregnancy and results in a very edematous, painful breast. Now there are some development abnormalities. As you can see in this picture over here, there can be aplasia or hyperplasia. In this there is complete aplasia of the breast. This is an uncommon condition which is associated with overdevelopment of the contralateral breast. Now some of these conditions can also be acquired because of irradiation to the chest wall for treatment of some tumors. And you can also have unilateral or bilateral amastia, which means there is absence of nipple. So this picture what is actually showing is the amastia condition where there is absence of nipple, breast ducts, pectoralis major muscles. This is a sex-linked recessive inheritance. There can also be presence of ectopic breast and aberrant breast. As you know, there is a milk line which extends from the axilla along the nipple areola and the both sides of the abdomen and culminates in the groin region. So along these milk lines on either side you can get presence of ectopic breasts. So these are also known as supernumerary breasts. These arise from the ectopic breast tissue which is present along these milk lines up to the groin and vulva. These are seen in very rarely seen in adult women and very rare, much rarer in men. You can also get unilateral axillary breast tissue. Now you call something as aberrant breast tissue when it occurs beyond the usual these milk lines, which is again a very rare condition, and in this case there is no nipple or areola. Now coming to some of the inflammatory and reactive conditions. So you can have fat necrosis. Now this can clinically simulate a malignant breast lesion. There is usually a history of trauma or a previous surgery, and microscopically if you see, there are areas filled of foamy histiocytes, foreign body type of giant cells, and lipid-filled cysts. That means this clear material which you see is actually fat-filled cysts. This can later on result in fibrosis, calcification, which appears egg-shelled, that means layered on imaging. In patients who have coagulopathy or are on anticoagulants, sometimes hemorrhagic necrosis can occur in the breast, resulting in a palpable lump. Breast augmentation surgeries are very common these days, sometimes for cosmetic reasons and sometimes for in patients who undergo mastectomy. So there are various foreign materials which are used for construction of artificial breasts, and these may sometimes rupture and give rise to a foreign body reaction and a palpable mass. Another condition which is seen in clinical practice is puerperal mastitis, which occurs very early in the second or third week of lactation in around 5% of the patient. Now, as you know, milk is a very good culture medium, so there is stasis of milk which allows growth of organisms like staphylococci and rarely streptococci, leading to abscess formation, and incision and drainage is the treatment. Now, there is a condition known as granulomatous lobular mastitis. The etiology of granulomatous lobular is most often unknown, and it is known as idiopathic granulomatous mastitis. The importance is that it may also present as a palpable lump or a radiological density suggesting a carcinoma. Another condition is, I'll be going into more details of this condition, is mammary duct ectasia, which can also present as a nipple discharge or a painful breast lump. Tuberculosis is not so uncommon in our country, and we have seen cases of frank tuberculosis involving the breast, and this may be either through hematogenous route or inoculation via the lactiferous duct. It presents as a slowly growing solitary painless mass. Now this clinical picture shows a typical erythematous, engorged, painful breast. This is usually sequelae of puerperal mastitis. And this microscopic picture over here shows a granulomatous lesion in the breast in the lobule. As you can see, these are some of the ductular units over here, and these are surrounded by a large granuloma along with mixed inflammatory infiltrate comprising mainly of lymphocytes and few polymorphs. So coming back to mammary duct ectasia is associated with nipple discharge and a typically subareolar mass. There is dilatation of major ducts in the subareolar region, which contains eosinophilic granular secretions, foamy histiocytes within the duct, and calcification. As you can see in this diagram, this duct is dilated. There are foamy histiocytes within the duct. There is periductular fibrosis and chronic inflammation. Now this occurs predominantly because of the obstruction of the ducts and giving rise to distension of the ducts, and as this secretion accumulates, they rupture the ducts, elicit an inflammatory response which leads to fibrosis. Now, as we look at the very good way of looking at the various lesions which occur in the breast is this diagram from Robbins. It has been appearing in all editions of Robbins so far, except they have modified it in the 10th edition. Now, as you can see, this is the, you're already familiar with the various units of the breast. Now, if you see the lesions, so some of the lesions which arise within the ductular units, as you can see, the large ducts, they are the source of duct ectasias, recurrent subareolar abscess, ductal papillomas, Paget's disease, which involves mainly the nipple. The stroma in between the breast ducts gives rise to fat necrosis, lipomas, fibrous tumors, fibromatosis, sarcomas, which are soft tissue lesions. The specialized stroma which surrounds the terminal duct lobular units gives rise to two very important stromal tumors of the breast known as fibroadenomas and phylloides tumor. Whereas the terminal duct lobular units, like these ducts, they give rise to the main lesions of the breast, which are the cysts of fibrocystic disease, sclerosing adenosis, the smaller duct papillomas, hyperplasias, epithelial hyperplasias, atypical ductal hyperplasias, and lobular hyperplasias, and carcinomas of the female or male breast. This kind of diagram helps you remember the various lesions and their origin within the breast. So now coming to non-proliferative breast changes, which are also known as fibrocystic changes, there are three patterns of morphological changes. Now this is a very common change which occurs during the reproductive age of any female, and These are also known as the lumpy, bumpy breasts. They may present sometimes with a palpable lump, which is nothing but a distended cyst. And the lumpiness is because of the smaller cysts and the fibrosis around them. Rarely they may be associated with a nipple discharge. So they typically give rise to cyclical pain, cyclical meaning during the various phases of the menstrual cycle. So it is relieved during the menstruation and the late phase, secretory phase, while it is more painful during the proliferative phase of the menstrual cycle. So in this particular thing, you see cysts, which are nothing but formation of dilatation of lobules lined. As these lobules they dilate, they atrophy the epithelium. So epithelium appears flat, and sometimes it may be metaplastic in the form of what is known as a apocrine metaplasia. So apocrine metaplasia, I will show you in picture, means that the breast epithelium has got abundant eosinophilic cytoplasm with apical snouts. Then there may be papillary projections, calcifications. Sometimes these cysts rupture, giving rise to fibrosis and chronic inflammation. And there may be also increase in the number of acini per nodules, which is known as adenosis. So as the word suggests, fibrocystic disease consists of cyst, fibrosis and adenosis. So this is a typical change. As you can see, these are small cysts of fibrocystic change which are filled with serous fluid, sometimes hemorrhagic fluid. These whitish areas are areas of fibrosis around them. And microscopically, if you see a fibrocystic disease, as you can see, this is an image of a TDLU. You can see there is increased number of glands per acini or per lobule. So these are known as adenosis, increased number of glands. These are surrounded by fibrous tissue. Some of these acini or ducts, they are distended and filled with secretions. So these are the cysts which are present, as you can see. There may be some calcification to which this arrow is pointing. And sometimes some of these acinar units in fibrocystic, they show a lot of pink cytoplasm and secretions. So in higher magnification, you can see this epithelium has got abundant eosinophilic cytoplasm, round nucleus, prominent nucleoli. These are the apocrine change, which is also a part of fibrocystic disease. And of course, you can see the fibrosis around them. So there are proliferative breast disease. What I have so far talked about is about non-proliferative breast disease. So there are proliferative breast diseases which are divided into proliferative diseases without atypia and proliferative disease with atypia. Today we are going to talk mainly about proliferative breast disease without atypia. So as the word suggests, proliferation means proliferation pertaining to ductal epithelium without cellular abnormalities suggestive of malignancies. Now in the proliferative breast disease without atypia, the relative risk of cancer is 1.5 to 2 times the general population. That means a patient harboring this lesion has only this much increased risk as would compared to a patient without these changes. Now what comes under this proliferative breast disease? It includes florid epithelial hyperplasia, sclerosing adenosis, complex sclerosing lesions or radial scars, papillomas. These are some of the lesions which come under proliferative breast disease without atypia. Before we go into details, what is epithelial hyperplasia? As you know, the breast ducts and acini are lined by dual layered epithelium. Now presence of more than 2 layers, cell layers, is known as epithelial hyperplasia. It is called moderate to florid when it is more than 4 cell layers. So what happens is this proliferating epithelium and myoepithelium cells, they distend the ducts and lobules and completely fill up the ducts. So you may have irregular lumens formed at the periphery of the ducts. So depending upon how florid the epithelial hyperplasia is, the ducts may be completely filled up. Now here are some of the images showing varying degrees of epithelial hyperplasia. So as you see, all of these are ducts with epithelial hyperplasia. This may be considered a little normal duct because it's probably having only 1 or 2 layers of epithelium. All the other ducts, they are showing increased thickness of the epithelium, and sometimes it is so florid that it is even occluding the lumen of the gland. So as you can see, and this is a higher magnification, so this is one duct or acinus which is showing marked epithelial hyperplasia comprising of proliferation of epithelial cells as well as the myoepithelial cells. Myoepithelial cells, they appear as these dark elongated nuclei, while epithelial cells are the other cells in this picture. Now as you can see, this epithelial proliferation has completely filled up the ductal lumens, and there is only small elongated slit-like spaces which remain to be filled up. So this is a typical feature of usual type of, we call this a usual type of epithelial hyperplasia. Why usual? Because it is not atypical. So this is the hallmark of epithelial hyperplasia, as you can see. So these irregular luminal structures, mostly at the periphery, the proliferation of both epithelial and myoepithelial cells, and depending on the severity, we characterize it as mild, moderate or florid epithelial hyperplasia. Another condition is sclerosing adenosis. As you can see in the picture, there is increase in the number of acini per terminal ductule. The normal lobular architecture is, however, maintained. What happens is, but because as the word suggests, sclerosing adenosis, there is sclerosis of the stroma or increased fibrosis, which leads to slit-like elongation of the ducts. So the ducts are compressed. So no longer you see such kind of dilated lumina, but you see compressed ducts leading to distortion, and these ducts may be dilated at the periphery but compressed at the center. Calcification is also frequently present in these lesions. So these are detected sometimes on mammography, and they may sometimes be palpable or mimic a atypical lesion or a carcinoma. Complex sclerosing lesion comprise of a mixture of sclerosing adenosis like changes and a change which is known as radial scar. Radial scar is nothing but a lesion which has a central fibrosis in which there are compressed ducts. This fibrosis seems to be extend in a radial spoke-like fashion to the periphery, where you see progressively more dilated ducts. So as you go to the most periphery of this lesion, you see dilated ducts, but as you come to the center, they are compressed ducts. This center is also known as the nidus. So this is another lesion which can mimic a malignancy on imaging as well as clinically. Now coming to the adenomas. So adenomas, as the word suggests, there is the increase in the number of glandular spaces within the breast unit, which is in some ways organized to form a mass-like structures. So you see it is actually a pure epithelial neoplasm of the breast. They are classified as tubular adenomas, lactating adenomas, apocrine adenomas, ductal adenomas, and sometimes a rare tumor, benign tumor of the breast, also known as a pleomorphic adenoma, the same kind of tumor which you also get in salivary glands. Lactating adenoma is a well circumscribed lesion. You have proliferating acini lined by actively secreting cuboidal cells, which have these apocrine changes and snouts and secretions within the lumen. This is another picture. As you can see, there are these hobnailing of these cells which are seeming to drop off from the epithelium, and there is proteinaceous secretion. So this is a typical lactational adenoma. Then you have tubular adenomas. As the word suggests, the glands comprise of tubules, small tubule-like structures which are present in an organized mass-like lesion. So you have tightly packed tubular or acinal structures, and the stroma in between is quite sparse. Then you can have similar tubular adenoma-like structure which is present just in the subareolar region. This is also known as florid papillomatosis of the nipple. It can give rise to erosion of the nipple, nipple discharge, and what you see just below the nipple are proliferating duct-like structures which seem to be invading into the stroma, but it is a benign lesion as it has a double-layered epithelium, and you can have keratin cysts and apical snouts in these lesions. Now coming to a lesion which is seen in both large and small ducts, but usually the lesions wherever they are present are the ducts are dilated. So as the word suggests, papilloma means it is a papillary lesion or a finger-like lesion with multiple branching, and they have a fibrovascular core with a connective tissue axis lined by dual layered epithelium. You can have large duct papillomas which are usually solitary, present in the larger ducts more proximally, and you can also have small duct papillomas which are present in the deeper ducts within the ductal system, and they are usually more often multiple as compared to large duct papillomas which are more often solitary, and they say there is a slightly increased risk of carcinoma arising in small duct papillomas as compared to large duct papillomas. So these are pictures showing these papilloma. As you can see, the duct is dilated, and in this picture you can see it has a fibrous core which has also blood vessels within it, so it's called a fibrovascular core, but it is lined by a dual layered epithelium. That means the epithelium has got both the epithelial and the myoepithelial cell layer. As you can see, this is a CK5/6, which is a myoepithelial marker, high molecular weight cytokeratin. Now there are atypical proliferative breast disease with atypia, which are have a higher relative risk. That means 4 to 5 times increased risk of having carcinoma as compared to a breast without this lesion. Now there are two main types of proliferative breast disease with atypia. One is the atypical ductal hyperplasia, where you have monomorphic cell population filling up the ducts, and they differ in their proliferation because of two reasons. One, they are monomorphic. Secondly, there is formation of round lumina as compared to an irregular elongated luminal space seen in a usual ductal hyperplasia. Then you also have atypical lobular hyperplasia, which is in which the cells do not involve more than 50% of the acini. In this also you see monomorphic proliferation of the cells. The only difference between these two lesions is that there is no duct formation within the duct involved by a lobular hyperplasia. That is why it is known as a lobular hyperplasia. And secondly, if you do an ecadherin stain, which is surface epithelial marker, there is a loss of ecadherin in atypical lobular hyperplasia, whereas the ecadherin is retained in an atypical ductal hyperplasia. So these are images of atypical ductal hyperplasia. Now as compared to the UDH which I showed you, these have got sharply round punched out spaces, and if you look at the cell, they are very monomorphic in appearance. So this is an example of an atypical ductal hyperplasia, and these four images show what is known as an atypical lobular hyperplasia. So you see the acinar units, less than 50% of the duct spaces are filled up, and these cells which fill up the ducts, they are very monomorphic, they don't form any ductal structures, and if you do an ecadherin stain, there is loss of ecadherin within these. Now coming to the two common stromal tumors of the breast, one is the fibroadenoma, which is also known as breast mouse. Why it is known as breast mouse? Because clinically it presents as a palpable nodular mass which is freely mobile in the breast. So when you palpate, it freely moves or slips under your hand. Therefore, it is known as a breast mouse. So it is the most common benign tumor of the breast. Typically occurs in the reproductive age groups. Nearly 2/3 of them have MED12 mutations. And grossly, if you resect out a fibroadenoma, it is a well circumscribed tumor. If you cut it, the stroma literally bulges out. So it has a grey white bulging cut surface, and there are small chink like or slit like spaces on the cut section. Microscopically, it is a typical biphasic tumor, just like phylloides tumor, which has both stromal and epithelial elements. We'll just come to the differences between phylloides and fibroadenoma a little later. So the stroma is very cellular and myxoid. So varying degrees of cellularity may be there, but usually in a fully grown fibroadenoma, it is a myxoid stroma. So the epithelium can be compressed or dilated, ducts and cystic spaces lined by epithelium. It is classified as pericanalicular when the stroma proliferates around the ducts, and intracanalicular when the stroma proliferation leads to compression of cleft-like ducts into cleft-like spaces. Now these fibroadenomas, they are hormonally responsive very much, and they grow in size during pregnancy and regress after menopause. Women receiving cyclosporin A after renal transplant develop multiple bilateral fibroadenomas. It is a known phenomenon. You call a fibroadenoma as complex, and why we classify something as a complex fibroadenoma, there was a slightly increased risk of malignancy in a complex fibroadenoma. We call it complex when the cyst is larger than 0.3 centimeters within a fibroadenoma. There is accompanying sclerosing adenosis, epithelial calcification, or papillary apocrine change. Even if 3 of these changes are present, it is classified as a complex fibroadenoma. So this is a gross picture. As you can see, it is a bulging gray-white myxoid kind of a surface, and you can see these slit-like spaces, chink-like spaces. Sometimes there may be areas of altered discoloration because of hemorrhage within the stroma, and sometimes this may be also a consequence of an FNAC procedure which may have been performed earlier. The size may vary from very small to huge sizes. And microscopically, as I said, it's a biphasic tumor, so you see a lot of stroma and compressed chink-like spaces This is a typical feature of an intracanalicular fibroma where the stroma grows and compresses the ducts which seem to be interconnected to each other. The stroma in a fibroadenoma is not usually very cellular. It does not have nuclear atypia or mitotic activity as such, and the margins are very well circumscribed, so it does not infiltrate into the surrounding breast. And this is a typical pericanalicular fibroadenoma where the stromal proliferation is there, but the ducts are not compressed, unlike in the previous picture. So this is also a particular pattern. Usually fibroadenomas show an admixture of both patterns, and the most dominant pattern is this intracanalicular pattern. Now coming to phylloides tumor, you can have three categories of phylloides tumor: benign, borderline and malignant. Now this characterization is done on the basis of many parameters. There is no single parameter which defines a tumor as borderline or malignant. So a typical benign phylloides tumor has a very well circumscribed margin, does not infiltrate into the surrounding breast. The stroma is moderately cellular, the nuclear atypia is mild, mitotic activity is present in the stroma but it is not very brisk in a benign phylloides tumor. So as you go along the spectrum from borderline to malignant, these parameters change. That means that you have more mitosis, more cellularity in the stroma, infiltrative margins and nuclear atypia. Now the age group for phylloides is different from fibroadenoma. It occurs a decade or two later than the peak age for fibroadenoma. And both these tumors, they arise from intralobular stroma, phylloides as well as the fibroadenoma. Like fibroadenomas, majority of these also have MED12 mutations. So grossly it may be small in size to huge size which may distort the entire breast. And microscopically this is also a biphasic tumor with the differences which I have already highlighted. So you distinguish it from fibroadenoma based upon higher cellularity, higher mitotic rate, nuclear pleomorphism, stromal overgrowth and infiltrative borders. So as you can see, this is a very large phylloides tumor which has been nucleated. The cut section shows myxoid, similar myxoid bulging cut surface along with some areas of hemorrhage and altered discoloration. But you can see the margins there very well circumscribed. And microscopically they have so much proliferation of the stroma that they sometimes give rise to these leaf-like fronds. So these leaf-like fronds which are present gives the name phylloides tumor. Phylloides means like leaves. So these fronds, they give rise to this nomenclature. So there are nodules of proliferating stroma lined by dual layered epithelium. Now the only difference is that this stroma now has more nuclear atypia, increased mitotic activity depending upon the grade of the phylloid, whether it is a benign, borderline or a malignant phylloides tumors. And usually it is the stromal component which overshadows the epithelial component in a phylloides tumor, and there may be the importance of phylloides tumor is that it may show a lot of local recurrences much earlier and much more frequently than a fibroadenoma. Therefore, the margins of resection are very important in a phylloides tumor. This is a higher magnification of the stroma. As you can see, the ducts are very few and sparse, and it's predominantly stroma which is known as a stromal overgrowth. So this is more of a stromal predominant lesion of the breast. So we come to an end to this talk, and what I have not talked about is basically the other stromal lesions which can arise from the connective tissue of the breast. For example, the adipose tissue can give rise to lipomas, the fibrous tissue can give rise to some fibrous lesions in the breast, and smooth muscles which may be present because of metaplasia in the breast can sometimes give rise to some smooth muscle tumors, and you can have various other stromal lesions which are very rare, and I think for undergraduate level this is what you need to know. Thank you very much for your patient listening.